Hello and welcome to the webinar today. My name is Emily Cossack and I'm the Knowledge Manager at the Canadian Institute for Public Safety Research and Treatment. It's my pleasure to be hosting this event made possible by a partnership with the Canadian Institutes of Health Research. Today, we continue our series on research done for the post-traumatic stress injuries in public safety personnel catalyst grants. There are a few housekeeping notes before we begin the presentation. All attendees are in listen-only mode. This is to limit the amount of feedback that we may get during the presentation. Just so you know, today's session is being recorded and all attendees will get a copy of the recording sometime within the next 48 hours, normally within 24. Please use the question box provided to you to ask any questions throughout the presentation. After the presentation itself is given, we will move to a question and answer period, so I look forward to being able to ask your questions. Lastly, we just like to let you know that some organizations do block GoToWebinar, and this means that you may have to join by phone instead of by video. So now I'd like to introduce our project for the day. It is a randomized controlled trial examining the treatment efficacy of a novel approach to cognitive remediation in public safety personnel with post-traumatic stress disorder and comorbid conditions. A bit of a mouthful, but I'm sure it'll be very enjoyable to learn about. It is going to be presented by Dr. Margaret McKinnon. She is the Homewood Chair in Mental Health and Trauma, Associate Professor and Associate Chair of Research in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. Thank you for joining us today, Dr. McKinnon. I am going to go ahead and share presentation control for you, so you can go ahead and throw up your slides. I do want to just let everybody know while Dr. McKinnon is doing that there are handouts attached for today. There are the knowledge report for Dr. McKinnon in both French and English and our agenda. So if you want to go follow along with that, you're welcome to do so. Dr. McKinnon, I turn it over to you.
Thanks so much, Emily. And let me just begin by thanking you for organizing today's webinar. I'm very appreciative of all of your efforts. And I'd also like to thank CIPSRT and CIHR for inviting me to present here today. It's really a pleasure to be here. As Emily had said, that is quite a mouthful. And because it is a mouthful, what I'm going to do today, as I'm the only speaker, is I'm going to slow things down a bit and take some time to explain what can sometimes seem like complex constructs on the surface, but we'll spend some time to talk to each other about them. Oops. So what I want to begin by doing is acknowledging our amazing research team. So this work was done in collaboration between a number of institutions and individuals. Ruth Lanius is the co-PI on this project, and she's at Western University. And this work was also supported by Colonel Rakesh Jetley, who's the Senior Psychiatric Advisor to the Canadian Armed Forces, Don Richardson at Western University, Randy McCabe at McMaster, Charlene O'Connor, who's at Homewood Health Center in Guelph, and she's one of the main developers of GMT. And it's really a pleasure to have Charlene on our team, as she has long-standing experience in this area. I'd also like to begin by thanking the many graduate students who worked on this project, including Jenna Boyd, who's now a psychologist at St. Joseph's Healthcare in Hamilton, Lena Protopescu, who's a psychologist now at Providence Health in Kingston, along with Chantel Lloyd and Amna Qureshi, along with our amazing project staff, which included Heather Millman at Homewood Research Institute, Andrea Brown at Homewood Research Institute, and Sarah Souza at Homewood Research Institute, and all contributed tremendously to this project, and we're very grateful to them for that. So really, where is this work rooted? What was the initial idea that led us to pursue the idea that individuals with post-traumatic stress injuries may struggle with cognitive difficulties, so difficulties with memory, with attention and focus, and with planning or organization. And back in 2014, the Homewood Research Institute hosted a knowledge translation session at the Canadian Institute for Military and Veterans Health Research, which is a strong partner of CIPSRT and CIHR. And there we asked members of the military community, along with the first responder community, what sort of research should we be doing? As academics, we always have a lot of ideas about what we should be doing, but we wanted to hear back from the community. What do you need? And what we heard from the public safety personnel community and the military community was they needed assistance with staying at work, returning to work, and in some cases making a transition from, for example, from military to non-military employment, or from the first responder world to another form of employment. And I'm a clinical psychologist and a clinical neuropsychologist. And I've had the absolute privilege to work with members of the military and first responder community clinically. What I would often do as a neuropsychologist is that I would see individuals who were struggling with post-traumatic stress injuries, and I would report to them that they had difficulty with their memory and with their attention and with planning and with organization. But when I did that, there often wasn't a treatment approach that we could offer to those individuals. And when we heard from the community that they needed supports around memory, focus, attention, planning, and organization, we set out to do something about this. And that was the focus of this grant from CIHR. So we do know that post-traumatic stress injury, it will come as no surprise to this group, that it really does impact on real-world functioning. And that real-world functioning includes difficulty interacting with one's family members. It may, for some individuals, include high rates of absenteeism at work. It can lead to unemployment in some cases, and it's also associated with difficulties on the job. So many people who struggle with post-traumatic stress injuries struggle to stay at work or struggle to come back to work after their injuries. And this is a focus of really the work that we're doing. We're interested not just in reducing symptoms of post-traumatic stress injury, but helping people to stay at work or to return to work after a post-traumatic stress injury. We know that rates of disability can be very high when tasks require high concentration and they have high cognitive demands. And we certainly know that is the case for public safety personnel. I was very privileged to grow up in a public safety personnel household, our first responder household, and a healthcare household. And I know the demands of this profession. I know how fast-paced it is, how decisions need to be made within seconds, how one is often concerned about being judged about those decisions that have been made. And so there's a real need for having your cognitive abilities, your focus, your concentration, your ability to plan and organize online as much as possible. We do know that once individuals with PTSI go off work, approximately 1 in 4 will return to work within a month, about 1 in 3 within 8 months, and about 2 out of 3 will be back at work 4 years later, but some do not return to work. And my clinical experience, along with that of my colleagues, really tells us that part of that struggle in returning to work can be difficulties with memory, focus, and attention. And of course, this comes at a cost to employees, but also families and also to municipal governments who are supporting workers who are off of work due to workplace injury or workplace stress associated with PTSIs. So we know that there is, in fact, a strong relationship between having difficulties with memory and planning and focus and the ability to, what we would say, be productive within the workplace. That's been observed in depression, and we would postulate that that's certainly the case within PTSI as well. We also know that having difficulty with tasks that require you to learn, even with motor functioning, which is very relevant, of course, to the to public safety personnel, all of this is predictive of having difficulties at home, at work, and in retraining efforts. And when we look at the diagnostic criteria, so as clinicians, how do we diagnose PTSD? Well, we do look, of course, at concentration as being, and we need to do that as part of the diagnosis for post-traumatic stress disorder. But we know from a host of different research studies that it's not just concentration that's impacted in post-traumatic stress injury. We know as well that individuals have difficulty with planning and organization, difficulties with memory, difficulties with how quickly they can process information. So people will often describe the PTSD brain, and that feels a little bit like brain fog sometimes. So Things feel slowed down. It's difficult to learn new information at times, and it's difficult to plan and monitor what one is doing. And often people attribute that to a sense of that they feel that there's something profoundly wrong with them. And I've heard the terms, I hate using this word, but patients have said to me, I feel stupid. I feel like there's something really wrong with me. And what I'm saying here today is that no, this is very common. It's part of the disease of PTSIs, and it's also part of the injury that occurs to the brain. And we've done a lot in our work in our group to show that injury to the brain. And part of that injury that happens results in these cognitive difficulties. And if we think about the first responder arena, the public safety personnel arena, it's not just that people have these difficulties, but they're in a very fast-paced, complex environment. So many people who struggle with PTSI may be in a slower paced environment with less decision-making having to happen moment by moment and second by second. But in the public safety world, we all know that it's fast-paced. It really requires us to be on task, to be thinking and making decisions rapidly in the moment. We also know that when individuals struggle with their memory and with their attention and with their planning, it really makes it does interfere with the ability to benefit from treatment, be that whether it's in psychological treatment, so talk therapy, or benefiting even from medications. So this suggests to us that these difficulties in post-traumatic stress injuries with memory and with attention and with planning are very important therapeutic targets. And I wish I could turn to you now and say, wow, we've done a lot of work to address this so far. But in fact, that has not been the case. And this trial, sponsored by CIHR, was one of our first opportunities to really address the difficulties with memory and attention and planning in post-traumatic stress injury. I'm just showing you here the present picture regarding treatment for PTSD. And here what we see, just looking at this graph, is that while many people enter into treatment for post-traumatic stress disorder, they may enter into treatment with very severe symptoms of PTSD. And what we say is that we can often bring people from here back to here, but we don't bring them back to that baseline functioning in many cases. And some we do, but for many people, we don't get them back to where they were before the injury occurred to their brain. And we would argue that these difficulties with memory and concentration and planning are one part of that unresolved picture in post-traumatic stress injuries. We also know that oftentimes it can be difficult to translate traditional treatment approaches to the unique public safety arena. I want to say to you from the outset that the clinical team that we assembled to do this work was highly experienced and has cultural competency with individuals with public safety personnel. The lead clinician for this group, Charlene O'Connor, had worked on the post-traumatic stress recovery unit at Homewood for a number of years before she began administering this treatment. And she really did bring a unique understanding of public safety personnel to this treatment. And I think that's very important for us as clinicians to have cultural competency in this area and to understand the world of public safety personnel. In our own group, we've looked at those injuries to the brain of individuals with PTSI, and we've sought to develop neuroscientifically informed treatments that stem from our work looking at the injury to the brain, identifying where that occurs, and then thinking about the treatments that would best target those parts of the brain that have been injured by post-traumatic stress injury. And one treatment based on this work that we've done that we thought may be of assistance to public safety personnel struggling with their memory and concentration and focus was goal management training. This is a form of treatment that was developed at Baycrest Center in Toronto for individuals who struggled with brain injuries, so with difficulties following a traumatic brain injury and with aging. And really what this treatment does is help people to realize, first of all, that they're not the only individuals struggling with this difficulty, that this is a normal expression of the injury to the brain that occurs with post-traumatic stress. It encourages people to be aware of the cognitive difficulties that they're having, and it helps them learn some strategies to deal with those that will be useful not only when we're teaching the skills, but should generalize across their lives to the family and to the home and to the work environment. So what do we do with this approach called goal management training? Essentially, what we do is we teach people to stop, to be in the moment, to think about what they're doing, to think about what their goals are, to break those goals down into sub-goals, and then continuously monitor and check. So really, it is just an overall strategy that we teach people to help them deal with the injury that's occurred to their brain by learning to stop, to think about what they're doing, to be in the present moment, to think about what their goals are, what their sub-goals are, and to go back and check continuously in that loop. And this treatment has been very successful in other clinical populations, including older adults, traumatic brain injury, individuals with ADHD, with substance abuse, with spina bifida. And what's very interesting is that unlike some forms of treatment for memory and attention and problem solving, the effects of this treatment seem to persist at follow-up. And that's very important because we don't want to just administer a treatment and then suddenly that treatment, the effects of that treatment stop right after the group ends. We want it to continue on after the time that we've engaged in the training. So we tested this initially at Homewood Health Center. I'm not going to talk very long about the results because I want to move on to the CIHR trial, but to give you a sense of what sort of impact GMT has, and this was a study done with public safety personnel who were receiving inpatient treatment at Homewood Health Center. And this is some of them talking about the impact of GMT on their brain. So one individual said before they had GMT, they said, when reading, my mind wanders within a minute and I have to reread the same paragraph over and over again. And this is often what I heard clinically from individuals that I was seeing who had post-traumatic stress injuries. They could not focus or concentrate on what they were reading. At the end of treatment, this individual said, I'm able to read a full chapter before my mind wanders. And believe me, for people who have post-traumatic stress injuries, including those who are likely in this audience, that is a victory. I can tell you that clinically with absolute confidence. Another person said that really validation was the key to this group-based treatment, where I knew that I always had difficulty with my concentration, my memory, but now I know that those difficulties are associated with my PTSD brain, and I no longer feel as angry or sad or project blame or stupidity onto myself for doing this wrong. And I want to tell you that's a very important aspect of this treatment, to help people to understand this is an injury to their brain and the difficulties that they are experiencing with many individuals with post-traumatic stress injuries. When we looked at the results of this study, we did see as well improvements in areas of cognitive functioning, and these included executive functioning, so planning, monitoring, and the speed with which information was processed, improvements in attention and verbal memory. People also learned to slow down and think about their goals, even when they were having difficulties with their emotions. So when they were triggered, for example, by an argument with a partner, or being on the road and someone made them angry, they learned to slow down and stop and think. But this study was done comparing GMT to regular treatment for PTSD on the inpatient unit. And with funding from CIHR, we were able to actually conduct what's called a randomized control trial. And what that allows us to do is randomize people to either receive GMT or to receive, in this case, they went into a wait list condition where we could compare whether people receiving GMT did better than people who were over the same time period who had no treatment. And people didn't get to choose the group that they went into. And what that allowed us to do is have a much more controlled setting to test the effects of GMT. We wanted to know whether GMT would improve performance on cognition, so measures of planning and performance, reducing that brain fog and speeding up processing speed, showing improvements on attention and also memory. We also wanted to see if individuals gained a greater subjective sense or belief in their cognitive functioning. Did they feel that they were doing better? We also wanted to look at the impact of GMT on functioning in the real world. So interacting with one's family, interacting in the workplace, staying at work, returning to work. And finally, we wanted to know if overall GMT would also help with symptoms of PTSD, trouble regulating emotions. So for example, being on the road, driving to GMT, becoming very angry, and stopping to think about the consequences before acting impulsively. We also wanted to look at symptoms of dissociation, of depression, and of anxiety. So again, what we did is we randomized people to receive either GMT or to go into this wait list condition while they waited to have GMT. Ethically, we did then offer GMT to individuals who waited afterwards, who had waited for the 3 months. We offered them the GMT, but we don't include their data in this analysis. We just wanted to be ethical and ensure that they received the treatment. So we did look at a number of measures. I'm not going to go over these in detail. These slides will be available for anyone who would like to see them, but we did use a very standardized neuropsychological assessment battery, much like I would have used in clinical practice. We also looked as well, not only at those neuropsych measures, those standard neuropsych measures, but we asked people questions about how confident they felt about their ability to, no longer have as many cognitive blunders, if their distractibility went down, how did they feel about their ability to remember names? How did they feel about their memory in general? We also used something developed by the World Health Organization to look at people's functioning in the real world, and that's called the WHO Disability Assessment Scale. And that looks at areas like mobility, self-care, socializing, work functioning. We also looked at traditional measures of symptoms of PTSD and of depression and anxiety, and finally that ability to tune down that impulsivity and regulate one's emotions. So I just want to tell you a bit about the group that was that participated in this study. And what's very interesting here is that individuals here, about 75% of the people who participated in this study were still at work. And what I would argue here is that GMT may be a very important tool to allow us to help keep public safety personnel at work when they're struggling with their symptoms of post-traumatic stress injury, by helping them to deal with those difficulties in concentration and memory and focus and planning. On average, we can see that while individuals fell above the cutoff score for a diagnosis of PTSD and what's something called the CAPS-5, which we use to measure PTSD, they're more in the mild to mild moderate range, meaning that while they have PTSD, it's not at the range of severity that we saw in that last inpatient sample who were receiving treatment on the unit. I'll also tell you, and nobody in the public safety personnel arena will be surprised to hear this, is that IQs were also above average in this group. Whoops, wrong way. So what happened? What were the results of this study? Well, I'm just going to go over this and explain this in what you'll see here is the results, and this is really for the scientists who are listening to this talk, but what I'd like to do is break this down into real world terms. So what areas did we see improvements on? Well, we saw an improvement in the ability to think flexibly. So we know that oftentimes when responding in the public safety arena, we need to generate not just one solution, but multiple solutions to a problem. And we saw an improvement in this area in individuals who participated in GMT, but we did not see that improvement in people over the same time period who were in the wait list control condition. We also saw an improvement in the ability to switch back and forth between different ideas. So often we can't remain fixated on one thing that's happening in the environment. We need to switch back and forth flexibly between two different things that are happening. And we saw an improvement in the GMT group in that ability that we did not see in the waitlist control condition. I'll just highlight that with these red bars. Against our predictions, we did, however, see an improvement on a task that required people to read words very quickly and also to dampen down an impulsive response. We did see that in the waitlist control condition, but we did not see that in the GMT group. And that was interesting to us, and we haven't yet interpreted that finding. When we've also looked at something called the tower, and what the tower is requiring you to follow a series of rules to move pegs across a pegboard. And oftentimes when people have post-traumatic stress injuries, they act very quickly and they don't stop to think before they make their first move. And that often is thought to reflect impulsivity. They also, they may move very quickly, and then when they make the move, so they do it quickly, but then they continue on very quickly to move the pegs around on this pegboard. What we found was in the GMT group, after they received GMT, they stopped, they waited for longer before they made that first move, and the time that they spent planning and making the moves on the pegboard also increased. So what we're seeing here is a decrease in impulsivity, as well as more time spent planning during the task. I can tell you that we also did a similar study in depression and in obsessive compulsive disorder, and has very similar findings. People became less impulsive and they spent more time planning. In addition, individuals with GMT, but not in the wait list control group, were better able to focus and pick out a letter that they were supposed to be monitoring for. So this is a task, the CPT detectability, which I show here on this bottom line. Here people are asked to monitor for a particular letter and press every time for everything that they see except for that letter. And with GMT, they became much better at monitoring for that letter. And that, of course, is incredibly relevant, again, to the first responder arena, where we're looking for signals, we're looking for, essentially, for difficulty or danger and monitoring for it. So these were improvements that were seen in the GMT group, but not in the group that waited over the same time period. In addition, we also saw an improvement in memory, which somewhat surprised us because it wasn't necessarily predicted by the ability to stop and think. But we use a task where people can use strategies to learn. And what we found was that at the end, on this learning, our memory task, people actually had better memory after they had participated in GMT than they did over a similar period of just waiting and not receiving the treatment. My suspicion here is that they've learned to stop and think about their memory strategies and thus improve their memory over time. When we ask people about their subjective sense of how they're doing, how do you feel? Is your memory, is your attention, do you feel that this has improved? We found again that this ability, the subjective sense, had improved in individuals who received GMT, but not in individuals who did not receive the GMT over the same time period. That's very important because oftentimes when people come for clinical care around their memory and attention and focus, they've also lost confidence in their ability. And that loss of confidence can be a downward spiral, which I'm sure many people in the audience are aware of, is that when we don't feel confident about ourselves, it makes it even more difficult to learn, to plan, and to focus. So it was really nice to see that in the public safety personnel who participated in this group, they also felt more confident in their abilities. Oops. I just want to go quickly through these results to tell you that when we looked at real-world functioning, so using that World Health Organization tool to measure real-world functioning, again, the improvements emerged in GMT, but not in the waitlist control condition. Similarly, we saw improvements in symptoms of PTSD, of depression, of anxiety, and in the ability to regulate one's emotions when under stress. What I often hear from individuals, for public safety personnel who have post-traumatic stress injuries, it's really important to remember that for most people with post-traumatic stress injuries, they don't have to go back to the place where they first encountered the trauma to go back to work. But for public safety personnel, when they go back to work, they're going back to the environment where they first encountered their trauma. And that can be highly emotional and highly arousing. And that can give rise to very emotional responses. And what we saw here is, again, GMT seemed to help people to regulate their emotions or have better control of their emotions, even in environments that were very distressing to them. I think that's a really positive effect of GMT that we saw on the inpatient unit at Homewood and people receiving treatment, but also out in the community with public safety personnel who were still working. So I just want to conclude overall that for public safety personnel who participated in GMT, when we measured their cognitive performance, we saw improvements in their flexibility, a decrease in impulsivity, improvements in attention, improvements in the ability to shift back and forth between different ideas or different tasks, and also to pick out a signal. We also saw that people felt more confident in their cognition. We saw improvements in their real world functioning, and also, interestingly, improvements on symptoms of PTSD, depression, and anxiety. Again, for the scientists and the audience, these were medium to large effect sizes, suggesting that these findings should be replicated in a larger trial, that they should hold in a larger trial. This work does support the earlier feasibility trial that we had conducted. And as well, what we would really like to know, we measured real world functioning using self-report measures, but I think we need to get out in the real world with our occupational therapy colleagues and really look and measure carefully real world functioning and the impact of GMT upon it. We also now have funding from CIHR to look at changes in the brain pre and post GMT. So what we're doing now is we're scanning the brains using MRI imaging of public safety personnel before they receive GMT and after they receive GMT. And what we expect to see here is a picture before GMT of the brain injured, and what we hope to see afterward is a picture of the brain healed. So I think this gives us tremendous hope for the treatment of post-traumatic stress injuries among public safety personnel. I want to conclude by thanking CIHR for this funding, but more so, I would like to thank the public safety personnel who participated in this study, but overall the public safety community for all that you do to serve and protect Canadians, particularly during this difficult time that we're all in right now with COVID-19. And really that comes from the bottom of my heart. So thank you very much for the opportunity to speak to you today.
For your presentation, Dr. McKinnon. It was very informative. As someone with a neuropsych background, I'm looking forward to the fMRI study just because that's where my background is. I just want to let people know, because we've had a few questions. If you are having trouble with the handouts that are there, we will be attaching them on our website after this presentation once the video is available. So just know that. And Dr. McKinnon, if you're comfortable with sharing, would you be willing to share your slides from today?
Of course, absolutely.
Wonderful. So then we will also add the slides from today to our website as well under this session so that you have access to them. First question for you, Dr. McKinnon, from our audience is, you mentioned the impact that PTSI and its effects can have on external support such as families. I was wondering if you could speak more to that and about how those impacts are being addressed.
Thank you so much for that question, and that's absolutely true. So oftentimes when people experience post-traumatic stress injuries, difficult situations in families can be really overwhelming because it's really hard when you have post-traumatic stress injuries to have control sometimes of anger or of strong emotions. So what may happen, for example, is that individuals with post-traumatic stress injuries may say things to a family member or to a friend that they don't really mean, but they say very quickly without having the time to stop and think about what they say before they do so. And what we found was with goal management training, in this case, people learned how to slow down and think about the consequences of what they said before they said it. So for example, when someone's feeling very angry and they have an outburst, oftentimes they have that outburst without stopping to think what the impact will be on others around them. And through learning this skill, people learn to think first what the consequences would be. And I think that's a very important skill that people can learn through treatment approaches like this. I would say as well in other work that we're doing, though, we also look at the impact of working as a member of the public safety personnel community and the other sorts of impacts that can have on families. So for example, for someone who responds to, for example, calls, so fire calls where the lives of children are lost, for police officers, correctional officers, paramedics who see, and dispatchers who see very difficult circumstances, they may feel that when they have these experiences that family members can't possibly share in that. And when they look at family members, it may seem as almost as if they're looking into the eyes of a baby, someone who can't appreciate the circumstances that a first responder has faced. And also many times we hear from public safety personnel and first responders that they don't necessarily want to tell these stories to their families because they're afraid that they may harm them by telling them the stories. So this is something that we try to address through treatment and also to learn more about. The other thing that I would say that's often heard from the families of first responders is that it's really difficult to leave a call or to leave a shift, drive home in your car, and then when you open up the door of your house, to go from being a first responder who's had a really difficult day to being a family member who's expected to be a mother or a father, a husband, a wife, a spouse, partner, within seconds when that door opens. And that can also be very difficult. And we often hear about that in the work that we do. So Heidi Cram is a really tremendous scientist who works with CIHR, who has done a lot of work around family members in the public safety personnel community. And that's some of the work that we hope to contribute to as well, working with Heidi and with others to really understand the impact of PTSI on family members along with public safety personnel.
Perfect. All right, next question is, did this project include any collection of and subsequent analysis of biometric health data? So something from a wearable health device, for instance.
Yeah, thank you for that question. We did not do that. I think it would be very interesting, though, to do so. I know Judith Anderson, for example, at University of Toronto at Mississauga, and Suzette Braymont-Harris out at the University of Alberta do that sort of work. And it would be very interesting to partner with them to look at the impact of this form of treatment on, for example, levels of blood oxygenation, on heart rate or heart rate variability, on the amount of perspiration that people experience going into a demanding cognitive task, or responding to a call, being on a shift. Do those biological markers change with treatment in addition to the injury to the brain? And I think that's a really important question to ask. Thank you for the question.
Next question is, did you carry out any qualitative data collection and analysis as part of this study?
That is also a good question, and that's what we're doing with our new funding from CIHR. We're actually doing a qualitative analysis as well. We did ask those questions that I showed you in the first study on the inpatient unit. We did ask questions about GMT, but we're now doing that in more detail with our follow-up team grant. One thing that Glenda McQueen said, and Glenda McQueen was the head of psychiatry at the University of Calgary and then the Associate Dean of Medicine. She was one of my mentors and she passed away this year. But what she always said about any form of treatment, that if it's not acceptable to the individuals who are receiving it, are not acceptable to the clinicians who are delivering it, then it doesn't matter how effective it is. So what we're really trying to do is receive feedback, qualitative feedback from the individuals participating, along with the clinicians delivering GMT, to really better understand their experience and where we can make further modifications to make this even better for public safety personnel who participate and for the clinicians who are delivering it, so they feel the most comfortable that they can be with its delivery as well.
So last question for the day here. The GMT appears very promising for facilitating several important gains for PSP. What are the next steps for propagating broad availability of GMT for PSP?
Yes, thank you for that question. So we received funding from the Cowan Foundation, the Military Casualty Support Foundation, and from the Cycle family, which is a philanthropic family in Ontario, to actually bring to trial GMT and occupational stress injury clinics in Canada. We've been doing that in partnership with the Quebec City Operational Stress Injury Clinic, and we have actually found that it's been a very promising implementation. We're now hoping to expand that implementation across Canada, and I would be very pleased to speak to anyone who would like to talk about that. With respect to uptake as well, Homewood Health now offers this in its outpatient settings. And we do also have funding from the Workers' Safety Insurance Board of Ontario to look at the impact on return to work outcomes in public safety personnel. So we have received a lot of support from different sectors for the implementation of GMT. We want to continue to do our work, but I would say that the signal has been promising enough that we've had partners who would like to implement this have been early adopters based on the promising signal thus far. And we're very grateful to those funders and the clinicians that we're working with in those settings to help us implement more broadly.
Okay, I'm going to make a lie of myself. I am going to ask you one last question.
Sure.
For sure. Is there any relationship between the subjective measures of cognitive improvement and the actual measures that you gave people, the more objective measures that you gave people?
Yeah, thank you for that question. So as a clinician, that's something that I often saw. So people would come for assessment of their thinking skills, so their memory, their attention, and their focus. And they may report difficulties with these, but sometimes when we did the testing, these difficulties wouldn't necessarily emerge through testing. And that was really problematic because it's not validating, first of all, for the individual, for us to come back and say, you know, everything looks fine on the testing. And what I want to comment, because I think it's really important for clinicians in the audience and also for public safety personnel to hear, is that, you know, first of all, neuropsych testing, this cognitive testing, is done in a very controlled environment. So with a very supportive tester, in a quiet environment with no distractions. When someone is functioning in the real world, so for example, responding to a call, being on a shift, answering calls as a dispatcher, that's a very fast-paced environment with a lot of distraction and a lot of triggers. So cognition can look very different when it's being tested objectively and when it's happening in the real world. The other thing that we saw in this study, which is not at all surprising, is that, you know, we saw that the first responders involved had higher than average IQs. So what can happen with post-traumatic stress injuries is that sometimes people can experience a drop in their skills. So they may go from high average to average. And none of us would want to lose that above average performance and drop down to average. So it's really important to be mindful as well of that even when people test as being average in their cognitive skills, that may in fact represent a drop from high average ability beforehand. So I think it's really important as clinicians that we're very aware of that. I know clinicians in the audience are aware of that, but I think that often accounts for when we sometimes see a difference between subjective reports of cognitive functioning and measurement of cognitive functioning. And these are some of the reasons that we may see for discrepancy. In this particular study, things seem to line up where there was a reported subjective improvement as well as measurement of an improvement, but that's not always the case. And I think those are some of the reasons why that may occur.
All right, so we will finish up for the day. I want to thank you so much for sharing with us the results of your work. I know that it's going to be really influential down the line. As we reach the end, I also want to ask everybody to complete the survey that is going to appear at the end of the session. You are going to receive a follow-up email tomorrow with a video of today's session. We do hope you'll join us for our virtual town hall on November 18th, titled "I Don't Think You Should Be Here, Understanding and Overcoming Gender Disparities in Policing." We'll also be continuing the post-traumatic stress injury series on November the 26th. So if you haven't already signed up, the link for both sessions will be available in your follow-up email tomorrow. Again, Dr. McKinnon, thank you so much for your time. We appreciate it. And thank you everyone for being here today. Please take care and stay safe.
Thank you so much, Emily, and thank you to everyone who attended. Bye.